Well, welcome to the monthly CSF Podcast, where we will discuss the latest papers in cytokine signaling and IL-6 biology. Now, all the content discussed is available in more detailed slide format at cytokinesignaling.com, our free resource website. For this month, there are 4 papers that we've added to the CSF website, of which I want to discuss 2 in this podcast. The first paper is brought to you by Dr. Zhang and is discussing the comparative effects of biologics and cardiovascular risk among older patients with rheumatoid arthritis. Now, the key background here is that rheumatoid arthritis patients are believed to have higher cardiovascular risk and mortality than the general population, and we consider that this resides at least in part in RA-associated inflammation. Now, there are prior studies that have found that anti-TNF biologics are associated with either no change or even reduced cardiovascular risk. The key results in this study are that the demographic and comorbid conditions were significantly associated with an increased risk of AMI and competent coronary heart disease outcome. Secondly, low dose, less than 7.5 milligrams per day, and higher dose, greater than or equal to 7.5 milligrams per day of oral glucocorticoids were associated with higher AMI risk, but only high-dose steroids were associated with increased composite coronary heart disease outcomes. During this study, tocilizumab was not associated with increased risk of AMI compared, for example, with abatacept. Now, what can we conclude here? Well, there may be a greater AMI risk among patients with RA-initiated and anti-TNF agents compared to, for example, abatacept. But it's important to note that the absolute rate differences were small, and this may reflect the decisions on which patients received which biologic. Tocilizumab was found to have a marginally significant protective effect on AMI, which may potentially again be the result of the contraindication to prescribing tocilizumab to patients with perceived high cardiovascular risk. And an important limitation of this trial was the lack of clinical data, such as disease severity or activity at the time of treatment initiation, given that active RA is a recognized risk factor for the adverse cardiovascular outcomes, and patients may be given different therapies based on that disease activity. Now, our second paper is from our colleagues in Japan and focuses on the SURPRISE study that compares adding tocilizumab to methotrexate with switching to tocilizumab in patients with rheumatoid arthritis with an inadequate response to methotrexate. The key objectives of this study was to compare the efficacy and safety of tocilizumab added to methotrexate and tocilizumab switched from methotrexate in patients with moderate or high disease activity. Some things to recall on the methodology: patients were aged 20 to 75 and diagnosed with RA of less than 10 years duration. They had to have moderate or high disease activity, designed as a DAS28 greater than 3.2 at baseline. Stable doses of methotrexate greater than 6 milligrams per week for greater than 8 weeks were required prior to enrollment, and patients were randomized 1-to-1 to tocilizumab add-on or a tocilizumab switch. The methotrexate dosage was maintained at the same dose at baseline for add-on groups. IV tocilizumab 8 milligrams per kilogram every 4 weeks were given in both groups. And data were collected through week 52 and included, amongst other things, tender joint count, swollen joint count, the HAQ Disability Index, patient global assessments, EGA, CRP, ESR, and matrix metalloproteinase 3 levels. The key conclusions are that tocilizumab added to methotrexate is clinically superior and radiographically superior to tocilizumab switched from methotrexate at the 24 and 52-week time points respectively. The switch group caught up on add-on clinically, but not radiographically. Charisma, a phase 2 trial in methotrexate inadequate responder patients, also found that tocilizumab combination therapy was superior to monotherapy. Tocilizumab added to methotrexate had a higher adverse event rate than the switch strategy, particularly in the area of hepatic presentation. And in the methotrexate inadequate response RA group, tocilizumab added to methotrexate more rapidly suppressed inflammation than tocilizumab, leading to probably the superior clinical efficacy in prevention of joint destruction. So that's a summary. Don't forget, all these materials are available online at the cytokinesignaling.com. Thank you for your continued support of the CSF, and we wish you all the best in this new year, 2016.